project and all of the work contributed by many other countries. This session is to reinforce the multimodal improvement strategy launched by the World Health Organization, which many of you I know have used for improving quality and safety in your organizations. This session, I hope, will provide a reminder of the importance of using a proven improvement strategy and allow you to have the information to share with others in your training packages. And the next slide. For the first part of the presentation, I will recap on what WHO's multimodal improvement strategy consists of and why it's important, and some of the evidence that we have about its success. I'm not here today to talk you through 300 pages of the WHO guidelines on hand hygiene in healthcare, published in 2009. Many of you, all of you, will be aware of the systematic review undertaken to look at available evidence which informed these guidelines. There are many references and a lot of valuable information whenever we are challenged on the importance of hand hygiene. To be able to use these guidelines is a great asset to all of us. As I say, I will not go through each recommendation. That is easy for people to do. What's important is to accept the evidence and implement that evidence today. An important paper published in 2013 by many patient safety experts, as you can see from this paper on the screen, looked at top patient safety strategies that should be adopted in healthcare now. This presents information, powerful information for us to rebuke the challenges that people bring to us about, does hand hygiene work? Is it that important? All the barriers, behavioural aspects that people present when having to adopt this action in their busy healthcare lives. But we have no excuses now based on the evidence available, while future research, of course, will be welcome. These experts have reinforced that hand hygiene is a top patient safety strategy. Out of the many things that they could have included in this paper, and there are other topics, the action of hand hygiene is accepted as that important. And that applies to countries all over the world, based on work that has been done. So to start this part of the presentation about the principles of a multimodal improvement strategy, and WHO's improvement strategy is one improvement strategy. There are many theories and principles, as you know, from many leading organizations. But what you will find with this multimodal strategy is aspects of improvement that we all adopt in our daily work and in our lives all of the time. These components are very clear and very much add up to a package of activities that will achieve success. And again, we have evidence for this. So you see on the screen, as a recap, the first component of an improvement strategy must be the system, the environments in which we work. They must allow us to be able to do the right thing easily to protect patients. For hand hygiene, that includes the products that are available to us, which we will discuss. The second component, which I'm sure none of you will dispute, is training and education. one component of ensuring improvement. Very important for reinforcing knowledge and ensuring understanding of all healthcare professionals, but just one aspect that will lead to success. The third component, monitoring or evaluation and feedback. Absolutely vital. It has been the cornerstone of infection prevention for many decades, following many publications, including the seminal work by Halley around sentinel surveillance. Monitoring and feedback will drive behaviours. That is one part of an improvement strategy. The fourth component, reminders in the workplace, social marketing, absolutely vital and very powerful in today's world with all of the resources we have at our disposal. But again, just one part of the strategy. While the fifth and last part is an institutional safety climate. What kind of culture are we all working in to ensure that these other four components can be easily adopted and applied in everyday practice? We will come back to each component, but firstly, I want to highlight for those of you who have not seen this, or as a reminder for you to share with your colleagues, the publication from 2013 which demonstrated that multimodal strategy applied in a range of countries. The work that began in the World Health Organization in 2006, working with colleagues in many hospitals, looked at if you could apply that strategy that I've just described and make it work in different settings. And for this publication, this included Costa Rica, Italy, Mali, Pakistan, and Saudi Arabia, while it has been applied and tested in other countries. A very powerful publication that I urge you to continue to refer to. In summary, it covered thousands of opportunities fed back from all of the hospitals involved in the study. They looked at 1,423 sessions pre-intervention of the improvement strategy and slightly more after the intervention was applied. And they measured this against compliance with hand hygiene, which increased here, as you can see. They measured it against knowledge, which also improved across all of the sites based on that one component of the multimodal strategy being implemented. And after the intervention, all sites reported ongoing hand hygiene improvement strategy and scale up. And it is important to note that the strategy implementation was significant and did have an effect even after adjusting for main confounders of other things that could have influenced behaviours and actions towards hand hygiene action. Just rapidly to explain more of the content of that paper, you can see here the different healthcare professions and their improvement in hand hygiene compliance before and after implementation of the improvement strategy. And you can see in all but one of the groups, there was a statistically significant increase in compliance. We also looked at the 5 moments for hand hygiene. That action, that recommendation that underpins all of the WHO strategy around patient safety and quality of care. And again, before and after the intervention, there was improvement in all of the 5 moments for hand hygiene significantly. There's a whole package, a whole suite of tools from WHO based on these principles that were first developed and tested in Switzerland, in Geneva, and then scaled up and, as I've described, tested across the world to be sure that such a strategy could apply to different countries. The whole package from WHO includes the 5 components that I have described, the 5 moments that underpins all of this for patient safety, and describes a stepwise approach to be able to implement this within healthcare settings. I'm going to recap on the principles of this strategy and how it relates to patient safety. The patient at the heart of a whole strategy, a strategy applied by healthcare workers, actually that always has the patient as the focus. And the patient focus is a patient, whether cared for in a bed or a chair or a dental chair or having renal dialysis, whichever setting, but a patient within their zone, within their area of care, and the application of moments for action that will protect that patient and healthcare workers and others. Simplify down into the 5 moments for hand hygiene. And the system change that I talked about is all around making it easy to do the right thing, and understanding the 5 moments allows workflow of busy clinicians to be engineered in a way that means they can perform hand hygiene at that point of patient care where the patient needs to be protected the most. Allowing for hand washing facilities and, importantly, alcohol-based hand rub at the point of care makes it easy to practice and remember and indeed monitor actions of healthcare workers against these 5 moments. So the system change, the environment, is absolutely critical. Our healthcare workers will not be able to act on hand hygiene recommendations within their busy workflow on a day-to-day basis. The 5 moments is at the core of training and education. It should run through all training sessions. We have a challenge to be sure that all of our training does not discuss other aspects of infection prevention or patient care without applying these 5 moments and highlighting where it's most important within the workflow of clinicians to apply one or more of the moments depending on what they are doing. So we have to focus the understanding of hand hygiene about doing the right thing for patients. Hand hygiene is, of course, conducted at other times during busy working days for the sake of the staff themselves, for food hygiene, but we're talking about patient safety, and having the 5 moments run through all training sessions is absolutely critical, including, for example, training on insertion of intravenous lines. The moments must be reflected appropriately when teaching doctors, nurses, phlebotomists, others to insert a line to take blood. We must make sure we have an embedded approach to hand hygiene education. Monitoring of hand hygiene is a staple of most countries around the world. The gold standard observation is recommended by WHO still, while other methods are being addressed and researched. But we must be monitoring against the 5 moments, understanding exactly when those moments should occur and whether staff are applying those moments in their practice. Feedback on other times for hand hygiene may be necessary for other reasons, but will not support the patient safety improvement that we are all striving for. Reminders in our workplace are vital, and although many posters and stickers and screensavers and many things are developed, we urge you to actually make sure the 5 moments runs through all of these. Marketing messages must be consistent, must be repeated over and over if we are to change behaviour. Therefore, it is vital that that patient zone, those critical times for hand hygiene, are reflected in all of our marketing reminders. The safety climate, the culture of our organisations is challenging. Leadership is absolutely vital. There's many examples from many countries now that we manage through the WHO programme, but it's very clear that the leadership is underpinning and vital to all of this, and without it, the other components of the strategy will not be able to stay alive and be sustained. It's challenging to have people understand what that safety climate is like, how it feels. There are a number of tools available to measure the culture of an organisation, and they do focus on leadership and role modelling, and it's something, again, we must continue to strive to. So to recap, we have 5 components of a multimodal strategy that should be implemented at the same time, but depending on your local environment and your progress, you can judge which aspect you would focus on most at any given time. This is important when we consider behaviour change. There are many behaviour change strategies, again, available to us. And what I present to you on this next slide is work by Susan Mitchie, a behaviour change expert from the United Kingdom, who looks at how we can influence the change in actions and long-term behaviours of our colleagues through capability, opportunity, and motivation. And that basic psychology is essential if we are to ensure the 5 moments and patient safety. And looking at our WHO improvement strategy, it can be simplified from the previous slide into teach it, the education part. It provides capability to drive behaviour. It can be broken down into building it, the system change, checking it, the monitoring, which all provide opportunity to drive behaviour to do the right thing. And the motivation can be driven by selling it through those reminders and through that organisational safety climate, living the actual things that we want to ensure happen, being role models and ensuring the 5 moments, the patient safety is always our focus. WHO have developed, as many of you know, over 40 tools to allow us to implement this strategy. Sometimes it can be difficult to know where to start. But we have actually decided that it would be useful to help people assess just where they stand in their ongoing improvement of hand hygiene action to protect patients. In this next slide, I present to you, as many of you know, the hand hygiene self-assessment framework. Let us recap briefly on the powerfulness of this strategy, this framework, to start people on their journey for improvement or to help them reach an advanced stage of improvement, to help them focus again on that improvement strategy and to know which components they should dedicate time and resource to if they want to achieve success. And as you know, and thanks to our colleagues in Spain who have very much supported the development of many of our tools, this tool exists translated into many languages found on the WHO web pages. This slide just shows you some examples of those available, but there are now many more. This framework, as well as the improvement strategy being tested, this framework was tested in many different countries. As you can see in this slide, this map of the world. And again, we present this information to reassure people that this can work for them. Many people will say, we are different, our setting is different, our organisation is different. Our work at WHO aims to help people use the tools in their settings without having to develop themselves and to understand that they can actually work. When considering the framework, it is an organisational level tool which takes on average 1 to 2 hours to complete. Just 1 to 2 hours to understand exactly where your status is with hand hygiene improvement. Many settings are doing this framework completion on a 6-monthly basis in order to monitor their progress and look to see what next steps they can take. It has a questionnaire-like structure, questions and indicators with a score, all of which were worked out with a group of global experts and tested, as I've explained. And based on the evidence of how improvement can be achieved and the detail in the WHO guidelines, the scores that are given, as these are the things that we know will best make it easy for people to perform hand hygiene as a routine habit as people progress through to advanced stage of implementing the improvement strategy. The framework gives us more than that. It actually guides us to the many tools available from WHO and similarly those that exist in healthcare settings. It guides us to tools that will help us take the next steps to achieve a greater score. Highlighted here, as you can see, is just one section where you score the sink to bed ratio, but there are a number of other indicators for system change, that first part of the improvement strategy, that are absolutely vital, including availability of alcohol hand rub in a continuous supply at the point of care. And definitions are given to help you complete this framework. The second component is then featured training and education. A number of indicators taken from the guidance, taken from the evidence, that are vital if you are going to continue to improve. Evaluation and feedback. Again, you complete your score for each section of the strategy independently, adding up your score, looking at how you're progressing against WHO recommendations, including for reminders in the workplace, and then for your safety climate. How much is leadership and role modelling existing in your organisation? Once each section is completed, and this can be done through a number of different ways, through having champions or link personnel in different settings, visiting a sample of wards, talking to your procurement services so that you know what products and resources are available, talking to management. You may have many of this information, much of this information available to you already, but you must validate and be sure that you complete this framework to the best of your ability, because it is powerful in helping you change the system, change your healthcare organisation and advance hand hygiene. Adding up each of the scores for each section and interpreting your results will allow you to present to staff, to management, to administrators, your progress. Being able to say that you have to advance, that you have much more work to do is powerful in dedicating resources. By being able to say you have progressed to intermediate or advanced means you can celebrate success and use it to continue to have resources dedicated, because you know that all of these components will help you to achieve the patient safety that you strive for. As I've described, there are 4 levels of results, and the majority of healthcare organisations around the globe are achieving intermediate or advanced. It's important that we continue to strive towards leadership. As you can see, there is a 5th component that should only be addressed if you've reached advanced level. And that's the type of work that's being shared around the globe with WHO in order for us to learn from people's success in healthcare settings, in order for us to know what could work in ours. So let's go back to the tools that are available to help you progress to leadership to advanced level. The right resources at the point of care, I've mentioned. This is essential. This year on the 5th of May, I continued to see a lot of reference to hand washing. And this is in countries where access to alcohol hand rub is available readily. And this causes concern given the WHO recommendations. Hand washing is, of course, acceptable and indeed recommended at times, while we know in order to address human factors and workflow, busy clinicians will not walk to wash their hands away from a bedside where they have, for example, to insert an IV line and a moment to for hand hygiene is essential. Alcohol hand rub, currently that recommendation allows us to make it easy to keep patients safe and to do the right thing. Hand hygiene must be the phrase around the world that we promote in order for people to understand the value of both hand rub and hand washing. The implementation tools that exist from WHO are many, and as I say, if you complete your self-assessment framework or you encourage others to do so, you can then be encouraged to use a number of tools to set up access to hand rub, to running water, to refurbishing, to have sinks in the right place. But you should revisit these tools, especially when staff are concerned about using hand rub, do not feel it suits their skin, their environment. Look carefully at assessing these feedback from staff to make sure tolerability and acceptability can be addressed scientifically, can be addressed properly, so that it can still be used at the right times in the right way. Training and education tools exist in many countries. And I urge you again to be sure that your training is clear and effective, that it is regular, that it is at least annual as recommended by WHO, while many are providing training much more frequently, because in these days it can be done in so many ways, not always by taking healthcare workers, busy healthcare workers, away from their clinical practice, but actually by doing it with them as part of their clinical workflow and helping them understand, again, where the 5 moments for hand hygiene will actually fit within their work. WHO provides a number of slides around the background reasons for why hand hygiene is essential and around application of the 5 moments for hand hygiene. The training videos are especially useful because they help people to see just where the moments fit in their workflow and help them to understand by challenging why hand hygiene should happen at certain times. We know that training of knowledge and background information will change behaviour to a degree, but it will not be embedded if people do not understand how it fits with their schedule. I've mentioned monitoring and evaluation and the standard that WHO has set, which is observation of hand hygiene practices, but also of the infrastructure, of perception, and of knowledge. By understanding this, you will understand the healthcare workers that you are dealing with, be able to provide meaningful results, and to work with them to understand how you can improve and make it easier for them to undertake hand hygiene. Data, as you know, is everything, and we cannot improve without it. But it must be shared meaningfully and through discussions that allows healthcare workers to suggest ideas for improvement. Again, many implementation tools, always recommending the self-assessment framework to help track your progress. The observation tools are available, as well as questionnaires. If you're looking at developing your own, we urge you to check these evidence-based tools that have been tested in order to be sure you can include the right detail within your own tool. There are many surveys for managers, for all staff, and repeated here are some of the other tools which don't just act as tools to assess the situation, but also do act as tools for training. Reminders in the workplace prompt and do remind us, but must work for the healthcare workers in that setting. It can be very powerful, but we all know that marketing tools eventually do not have an impact. So refreshing those and remembering that it's only one component of a multimodal strategy is essential. WHO has many, many tools for you, reminders in the workplace, with just some of these featured here. I urge you to check the WHO web pages this week, next week, for all of the new resources that have been developed for 5th May 2014 as part of the Hand Hygiene Global Campaign. Many of you will have used these. The response and feedback from countries and hospitals has been even more than ever, and many of you have translated these tools and resources already. I urge you and others not just to use these around 5th May, but all year round. There are videos and a brand new screensaver which highlights the 5 moments and how it can prevent the spread of antimicrobial resistant germs. This is available and is a very powerful tool again to be used to remind people just why hand hygiene is important. The safety climate reminder about the tools available from WHO. You can see an example here of a chief executive in a London hospital being part of a leadership campaign to remind people the importance of hand hygiene. Again, many tools available from WHO. We urge you to use these as part of a strategy. All of these aspects should be considered on an ongoing basis. And it's all about the point of care, bringing it back to the patients where hand hygiene is most vital. Those 5 moments and why that point of care is essential is based on work that was done looking at the risk of microbial transmission and also the human factor elements that exist that will influence behaviour and help people to be prompted about the needs of patients and why clean hands at moments when touching them is so vital. The definition of point of care is clear. 3 elements come together: the patient, the healthcare worker, and some kind of care or treatment. And that's crucial. Moment 1 for hand hygiene was first called before patient contact. After the testing and considering the importance of marketing within this, the importance of language, certainly in English, it was vital that that phrase was changed to before touching a patient. When revisiting the point of care definition, when encouraging our colleagues to know why these 5 moments are so vital, we must emphasise it is about the touch, the contact per se, but that word often is used just when people are talking to each other. And we have challenges when doctors visit patients just to talk in their patient zone at that point of care, but just have a conversation. The 5 moments wording, that moment 1 before touching a patient, must remind us all that we must fit the moments for hand hygiene within workflow around touch. That is how the bacteria are spread, and we must not insist on inappropriate or redundant times for hand hygiene, when in fact that turns people off to this action that could save a life, turns people off to the understanding of just how important it is and how germ transmission happens. So we must focus on those words and on these definitions. The purpose of measuring against the 5 moments, again, is vital because the degree of compliance during daily work routine must be clear for all healthcare workers and must be meaningful to them when it's fed back in order to plan future promotion that will help remind people of the times when they're failing hand hygiene, to help inform education, not just to give the same training sessions each time, but to target it to your healthcare workers, and to actually make sure that management Administrators have the right feedback so that they will commit resources and will actually make sure that the culture is right within healthcare to support the 5 moments for hand hygiene. I've recently been training hospitals all over the UK and in Europe, and it's encouraging to see management and administrators be willing to be trained on what the 5 moments for hand hygiene means. If leaders do not understand what it means, they will not be able to appropriately support the healthcare workers to improve. This is the WHO tool for observations, as I'm sure you're aware, which provides a compliance rate, all focused on the 5 moments. Before touching a patient, and you see here examples. Excuse me, the slide is just not moving. You see here examples of before touching a patient. Very helpful phrases, you may create your own. And this is important if we're to be sure that people really understand what this means and we can remind them to do it frequently at the times when it matters. Moment 4 is vital after touching a patient. And then again, we want to be sure we don't spread germs to other patients and that we reduce the burden of microorganisms within the general environment. Examples again are given here, wording that you can translate and have available to help people understand. Moment 5, always a challenging moment to understand. But again, it's about reducing the burden of microorganisms in the environment, and it's about understanding that patient zone. That bed, even if the patient is not in it at that time, or if someone enters the zone, does not touch the patient, but moves their equipment, checks an alarm, that to an extent is like touching the patient. Their germs will be falling around that patient zone that is defined by WHO, and we want to be sure that we do not spread these germs around to others. What's vital, however, and let me come to this year's WHO 5th May call to action, the role of hand hygiene in preventing the spread of drug-resistant organisms. We're really looking at critical sites as WHO defines them, sites where there's an infectious risk to the patient, a risk not just from colonization through touch, but through accessing and breaching the body systems which can directly result in life-threatening infections. And this is moment 2. It absolutely is the last chance to protect a patient from a harmful microorganism that could cause harm, death, and serious ongoing repercussions. Moment 2 again can be defined easily around blood samples, suctioning, examinations, anything that breaches that skin integrity where organisms have a greater chance to take hold and cause infection. And thinking about moment 3 and the many drug-resistant organisms that are presenting themselves in our environment today, we're not just protecting the patient from the next touch we may do, but protecting ourselves and others through organisms that may be existing within blood or body fluids. So a moment 3 frequently follows a moment 2, more than likely follows that procedure, that invasive procedure that has been undertaken, and they're both essential immediately before moment 2, a clean procedure, and immediately after moment 3, that body fluid exposure risk, whether gloves are worn or not. Gloves can be a huge distraction, and the work done by WHO emphasises these moments apply whether gloves are worn or not. The stepwise approach to implementing this improvement strategy, which is tried and tested and will resonate with you. It's similar to other improvement strategies. It makes sense. It's something we actually do inherently. It's something that we know will help us improve many things, not just hand hygiene. But a stepwise approach to applying all of the components based on the results of your self-assessment framework is also important in your planning. WHO has estimated the steps over the course of a year. The facility must be ready to accept an improvement strategy, otherwise our efforts will be in vain. There must be baseline evaluation. We know that data is vital and can be powerful, and if we don't have a baseline, people will question the improvement approach that has been taken. There must be an implementation phase, and we must all be dedicated to taking enough time to implement and not be distracted and not think that it isn't working and give up too soon. This is a common failure for improvement strategies. Dedicating the time for follow-up evaluation so that you can compare with the baseline, and then actually being able to action plan across the facility and continue to review will lead to success, and this has been demonstrated. I'd like to share with you, which is not on the slide, and recommend that you visit the WHO web pages, because on the 5th of May, this Monday, just one of the stories of improvement from one country, Costa Rica, was featured as a WHO main page improvement story. A story that has enhanced the lives of patients in the hospital in Costa Rica where the improvement strategy was first implemented, but in fact it has now been spread across the country and the region. And that Costa Rica story is powerful to help us all know just how important it is to use this strategy and to prepare and to be dedicated to a stepwise approach to improvement over time. This can sustain efforts, this can reduce healthcare-associated infection. It's a lot for facilities to consider. 300-page guidelines, many tools, a stepwise approach. Testing the temperature of your facility today and on an ongoing basis will truly help to achieve this. I come back to the framework and how vital it is. It only takes 1 to 2 hours to assess a whole facility and to understand what tools you can use, what you can do next to improve hand hygiene. And let's be honest, we can all improve hand hygiene. There are many, many advanced facilities who have been working on hand hygiene for many years, who are now willing to be honest and accept that when they observe hand hygiene practices of the 5 moments at the point of care, the hand hygiene compliance rates are still very, very low at 30%. A lot has been achieved, but I don't think we believe that it has been sustained, and we must focus on how we can do that. The self-assessment framework will help this. But embedding hand hygiene, as I mentioned earlier, excuse me, into everything that we do, not seeing it as a standalone added burden to the many activities that we ask healthcare workers to do. It's seeing where those 5 moments fit within interventions, within care bundles, within the workflow, and helping clinicians understand the importance of this will take us to the next stage of hand hygiene improvement. Use the action plans. Be sure to action plan. There are examples from WHO. And at the end of the day, hand hygiene is an intervention based on evidence-based guidelines that will dictate the outcome of patients. If done reliably, and reliably is the key word, which I don't believe we've achieved, this will prevent harm. And it is in part because of inadequate adherence and implementation of guidelines and improvement strategies that patient death still happens. Harm is the third leading cause of patient death still in healthcare because of inadequate implementation and planning to be sure that people can do the right thing easily. Hand hygiene is a key quality indicator and should be applied now without any excuses, without any barriers. This has been recommended. We must use that powerful article recently issued to convince our colleagues. A multimodal strategy will help us to do that, and WHO tools, along with all that you do in your countries and that you share across this project and with WHO, will actually be sure that we can protect our patients, like this man who lost his leg through MRSA in England. I'm going to finish just in a couple of minutes, and although these slides do not include all of the information about this year's WHO 5th May Save Lives, Clean Your Hands campaign, I want to emphasise some of the reports that have been issued that allow us to see hand hygiene within the importance of patient outcome as related to antimicrobial resistance. That huge challenge that is a global concern, an Armageddon as some are calling it, because of the lack of antibiotics, of new antibiotics available to us, of the increasing antimicrobial resistance that exists in many, many countries despite efforts to control it, of the work we still have to do on the misuse of antibiotics. Let us stop to consider that fundamental aspects of infection prevention will be the mainstay of how we protect our patients while we fight antimicrobial resistance. Two new reports have been issued by WHO. One on the global surveillance of AMR, a lengthy document that contains a lot of detail, a lot of data, trying to summarise all of the information available to date that will actually raise again the profile of AMR on the agenda of countries across the world. And another systematic review summary, which is looking at the role of hand hygiene in preventing drug-resistant germs. Many of the individual studies you will know, while summarising this, again allows us the opportunity to prevent just how powerful hand hygiene action at the point of care, especially considering moments 1 and 2 and 3 around protecting those patients and the spreads of drug-resistant germs. It really does give us the opportunity to highlight this to our colleagues, highlight the evidence that we have. Hand hygiene, as you can see from this new image available from WHO, really can protect patients all over the world. There have been numerous new posters issued and translated by WHO. As I mentioned, a new screensaver, new reports, videos, many resources available to you so that action does not just happen on 5th of May, but on every day, and that we can join hand hygiene up with patient outcome, those patients who are being affected by drug-resistant organisms. There are a few references to conclude this presentation, and I highlight these as well as, of course, the WHO web pages in order for you to look at what's available to convince our colleagues. But there are also a number of human factors and behaviour change documents available. The Health Foundation in England last year published a paper on infection prevention and human factors, a call to action looking at the evidence that's available around behaviour change for infection prevention, but asking our infection prevention colleagues across the world to work with behaviour change experts to look at how we can advance because we have the evidence, we have the research and the papers around infection prevention, but the hardest part is to change behaviours in the long term, and that includes of individuals in healthcare, but also of those leaders that we need to convince to ensure the right safety climate exists to allow hand hygiene to happen at the point of care. So I urge you to take a fresh look at all of the resources available as part of this project, as part of your hospital country activities. I want to thank you again for the opportunity to be part of this, to remind you of what's available, and to thank you all for the work that you do, and to ask you to continue to communicate with WHO and to work with us on examples of success. Thank you.
Thank you, Dr. Kilpatrick, for the interesting and complete presentation. I have a bad news, actually, as Dr. Gonchev is unable to make his presentation today. The reason is that apparently he has not access to any internet connection today. The building he is working from has no internet today. Sorry for the inconvenience. And Dr. Kilpatrick, we received a number of questions for you. Would it be possible for you to answer
yes,
right now?
Yes.
You have a copy of the questions in your chat box. The first one says, in your opinion, which is the hardest component of the multimodal strategy to implement? So which one has more barriers?
In my opinion, the safety climate, ensuring a culture that will support all of the other components. Training and education is accepted as an activity that should exist. While not every hospital in every country does dedicate resource to this, posters are often available and can be cheap and easy to make locally, and of course are available from WHO, so there's no resource required. Running water exists in most countries, and alcohol hand rub is available in most, and indeed in, I think it's approximately 40 countries now. They are producing their own alcohol hand rub as per the WHO formulation and doing this inexpensively. So there we have addressed the system, a big part of which WHO aimed to do. And the programme of work that I lead on for WHO is called Private Organisations for Patient Safety, where WHO is working with industry through corporate social responsibility to continue to advance the affordable, reliable access to hand rub in all countries. So many components have been addressed, but having the leaders consistently supporting this priority to make a safety climate every day is challenging. Even if we have leaders engaged, sometimes they leave the hospital. They are convinced that other priorities are more important and that hand hygiene is fixed, that is no longer a problem. And we know that we haven't changed the behaviours of all healthcare workers. So definitely the safety climate is most challenging. And as I say, I urge people to be sure that they engage senior leaders and managers and administrators when implementing hand hygiene improvements. I teach on hand hygiene often, and the people who are sent to hand hygiene training are the most junior staff. They are important, but it's because people think hand hygiene is easy, is simple, and it's not. There is a lot of evidence to demonstrate how, as adults, applying hand hygiene at the point of care is not intuitive to us. So I recommend that as one part of the safety climate change, one of the first steps is actually engaging senior managers before you start to plan any more hand hygiene improvement. It is unfortunate today that our colleague cannot join us. My presentation does not include the many examples from many different hospitals because we were about to hear examples from Europe. And that's disappointing because there are so many examples of how people have in hospitals, and WHO web pages do not have the facility to share all those examples, while our country network do share between themselves. And as again I'll say, the Costa Rica story featured in the WHO web pages is a good example for you to share with others. I'll move on to my second question, which is, why do you think there is lower compliance in moment 1, even after the intervention? When we are dealing with hand hygiene, we are dealing with invisibility. Those organisms we carry on our hands are invisible. Therefore, to change the behaviour of our healthcare workers who cannot see these germs on their hands, who are just quickly touching a patient's skin, who maybe cleaned their hand 10 minutes ago and touched many other things, but do not see that touching a patient after touching the healthcare environment will potentially cause them harm. This is a huge behavioural challenge. Moment 1 tends to be the lowest complied with. And it is essential that we focus healthcare workers on their workflow and how we make it easy for them to do it at that time. While moment 2, of course, is most critical in preventing those organisms from entering the patient's bodily system. And if your compliance is low, and it is a lot to address, including moment 1, if moment 2 is low, that of course has to be a starting point from a patient safety harm perspective. Lastly, the question is, do you think some kind of positive reinforcement or certificate issued to hospitals meeting a certain level of compliance would be positive? Certainly many have, not just in the field of hand hygiene, but in the field of improvement, have actually undertaken this positive reinforcement. Some have used punitive measures, negative feedback, punishment. There is no one set recommendation for this because it will depend on the local culture. And I urge you to test different approaches and to look at understanding, for example, the power distance that exists in your country. A publication by Dr. Michael Borg from Malta on the Journal of Hospital Infection looked at different cultures and how they affected MRSA reduction. Understanding your culture will help you understand what types of measures like rewards or punishment or other aspects will actually improve hand hygiene. While I must emphasize again that the 5 components of this strategy must all work together in order to improve hand hygiene. If you focus just on rewards or just on reminders, we know that that will not have a sustained effect. I'd like to conclude there. I've answered the questions, and I hope that in the future we can continue to share examples of challenges and of successes. And again, I just urge you to continue to look at the WHO tools, take a fresh look at them, and I thank all of my colleagues in many European countries for supporting the WHO work.
Thank you very much, Dr. Patrick. Thank you again, and we apologize again for the inconvenience we experienced with our second presenter from Bulgaria. I am sure he will be available soon for a specific additional webinar on his case study. I would also like to thank all the participants and remember that national examples of hand hygiene interventions are available on the PaSQ website. as much as a record of this webinar. That will be available in the next day. So yeah, check out the PaSQ website and explore it. Feel welcome to get in touch with us and all the PaSQ partners for your questions and for any kind of further assistance. Thank you again, everybody, and have a nice weekend. See you next.